Assalamu alaikum. I'm Farhana Lootah from Imperial College London Diabetes Center, head of the Cardiometabolic Renal Clinic. And we're going to be talking, Dr. Omer Ali is going to be talking about obesity and kidney. Dr. Omer Ali has joined us over about 2 years ago from Barts, UK, a consultant nephrologist. He has many interests and experience in acute kidney disease, diabetic nephropathy, and transplant. He also has joined us and contributing positively in our clinic, where we do a multidisciplinary approach of managing many diseases as well as kidney. So Dr. Omer Ali, where is he? He's back. Please welcome him.
Thank you very much, Dr. Farhana. Assalamu alaikum, good afternoon. When Dr. Sarah asked me to deliver this lecture without much thought, I said yes. But when I looked at the list of speakers, I immediately wished I'd said no. I think it's a privilege and an honor for me to be amongst the distinguished speakers. And I think you will all agree with me, it's been a fantastic conference with even more to come. So I'm going to talk to you about obesity and chronic kidney disease. We're going to go over the epidemiology very briefly, obesity, the association between obesity and chronic kidney disease, the mechanisms, the pathogenesis, and the treatment of obesity and chronic kidney disease. So obesity rates are increasing at an alarming rate. More than 2 billion people around the world are either overweight or obese. And this is more relevant to us in the Middle East and North Africa, because you can see 2 of the top 3 countries are actually within the region, Egypt and Saudi Arabia. And you can see the rates are increasing at significant, so by almost 50% in the last 30 to 40 years. So these are scary numbers. But it's not just the Middle East and North Africa. You can see the entire world, there's a projection towards an increase. And with the increase in obesity, there is obviously an increase in diabetes. And around the world, there's about 500 million people who have diabetes. And this is projected to increase by 100 million in just the next few years. In the background of all of this, there is a silent epidemic of CKD. So CKD is more prevalent than diabetes. Just short of 1 billion people have some form of chronic kidney disease. And the death rates from CKD is rising pretty rapidly. In 2013, it was the 19th biggest killer. In 2017, it's the 12th. In 2040, it's projected to be the 5th biggest killer. So this is moving very fast. In terms of the causation of this epidemic, it's largely been driven by diabetes and hypertension. No surprises there. And because of the association of obesity, diabetes, and chronic kidney disease, and its effect on cardiovascular disease, it has led to the development of a new syndrome called the cardio-kidney metabolic syndrome. And the main aims of this is really to educate people about the origin of this disease and the sequelae of them in terms of the amplification of CKD. But more importantly, it was to put the kidney right in the center, and that's why they called it cardio-kidney metabolic syndrome, because a lot of people knew for a very long time that diabetes will kill you because of cardiovascular disease, but people did not know that it's the kidney that really drives that amplification significantly, much more than diabetes alone. And you can see here that it starts with obesity, and then you develop hypertension, you develop diabetes, dyslipidemia, but once you have CKD on top of that, you are on a slippery slope onto stage 3 and 4, which carries the highest risk of cardiovascular disease. And just to put this in perspective, if you have diabetes alone, your risk of dying from cardiovascular disease is about 6.7%. But if you have CKD alone, your risk is much higher at 10%. If you put the 2 together, the risk doubles to about 20%. So it is the CKD that's amplifying that risk of cardiovascular disease. And if we look at what kidney disease means in terms of the stratification for cardiovascular disease, we see this sort of a picture. So at the bottom, you see this is the level of eGFR, kidney function, and you'll see the different degrees of proteinuria. So in black, it's normal proteinuria. In green, it's moderate proteinuria. And in red, it's a severely elevated proteinuria. And as the kidney function diminishes to about 60 or so, the risk of cardiovascular disease starts taking off significantly. And if you get to an eGFR about 45, you're twice as likely to die from cardiovascular disease, even if you have no proteinuria. But if you have proteinuria as well, the same relationship exists, but it's all reset at a higher level. What I mean by that is that the same eGFR, 60, no proteinuria, you're twice as likely, but if you have proteinuria, you're almost 8 times as likely to die from cardiovascular disease. And look at this, if you have a normal kidney function, no proteinuria, you are not likely to die from cardiovascular disease, but if you have proteinuria with a normal kidney function, you're 4 times more likely to die from cardiovascular disease. So the take home here is if you have kidney disease, it's bad news, but if you have proteinuria as well, it is very, very bad news. So where is the evidence linking obesity to chronic kidney disease? Is it just all mediated via diabetes and hypertension, or is there something else in the background? This paper published recently set out to address exactly that question. They looked at a very large number of patients. Look at this, 4.5 million people. And what they did was they compared those individuals who have obesity alone with no metabolic disorders to those who have either 1 or 2 of metabolic diseases such as hypertension, dyslipidemia, or diabetes. And what they found was if you have no metabolic abnormalities and you're overweight, you are more likely to develop CKD. And if you have obesity, you're even more likely to develop CKD. That the risk is about 1.7. So these are completely healthy individuals. We're not talking about individuals who have obesity or hypertension. And obviously, if you have 1 or 2 metabolic disorders, the risk is much higher. What about the risk of developing proteinuria? I just told you that if you have proteinuria, your risk is much higher because of the cardiovascular death. If you are overweight with no metabolic abnormalities, you are 1.7 times more likely to develop proteinuria. If you are obese with no metabolic abnormalities, you're 3 times more likely to develop proteinuria. So this is an independent risk factor for developing proteinuria, which is bad. And again, if you look at the metabolic abnormalities, the more metabolic abnormalities you have, the higher risk you're likely. This is another study. Look at this number, 5.5 million people, looking at adiposity and the risk of declining kidney function. What you see here is that as the BMI moves north of 25, your risk of developing a declining eGFR increases significantly. And in particular, once you cross that 35, the risk really doubles. And it doesn't really matter what level of eGFR you have. Even with a normal eGFR, if you have a high BMI, you're at risk of a progression of CKD. For those of you who are still not convinced, this is another data published very recently, so earlier this year, looking at adolescents. So these are young individuals who are completely otherwise healthy. They looked at a large number, again, 600,000 patients of the age of 16 to 20. They followed them up for about 13 years or so to see if they develop CKD. And as I said, these are completely healthy individuals. And what they found was the highest BMI developed CKD in their early adulthood, so in the 20s and 30s. And what this data is telling us is that early exposure to obesity carries an aggregated risk of developing CKD. So the longer you have obesity and the more early you have obesity, you are likely to develop CKD. So I think I've convinced you so far that there is an independent risk factor, obesity, linking to CKD. So what is the nephrologist got to do with this? Well, this is the prevalence of CKD and obesity. So the obese patients are in our clinics. We see them on a daily basis. 72% of patients presenting to CKD clinic have an elevated waist circumference. 50% have a BMI more than 30, and 26% have severe obesity. So these patients are in our clinics. We see them on a day-to-day basis, and we can't simply just sit back and ignore the problem. So what does obesity do to the kidney? This is histological changes that happen typically with obesity. You can see this glomerulus is the normal glomerulus, and this is a glomerulus from an obese patient. These are exactly the same magnification, and you can see how enlarged this glomerulus is. And this has all been driven by the capillary dilatation, which really causes hyperfiltration. Here you can see that there is a lot of scarring, and this is what we call FSGS, so focal segmental glomerulosclerosis. You can see there's a lot of scarring within the glomerulus. And here, this is where the whole story starts. This significant dilatation of the afferent arteriole is really what drives the hyperfiltration and the damage to the kidney. This is electron microscopy, so this tells us a different information. This tells us about the basement membrane, and it tells us about the podocytes. So the podocytes sit just over the basement membrane, and they protect the integrity of the basement membrane and maintain the filtration barrier. What you can see here is there is an effacement of the podocytes, which leads to dysfunction of the filtration barrier. And here, what you can see is a fat deposition within the kidney cells. So this is the equivalent of a fatty liver that Dr. Rubai has just said. But we do not appreciate this on an ultrasound as we do with the liver. So this takes us to the mechanism of obesity. How does obesity cause all these problems? And it's a multifactorial. There's the hemodynamic changes that I've just talked about, the intraglomerular hypertension, the podocyte injury, the sheer vascular stress with the dilatation of the arteria I've shown you. There is the obesity intermediate diseases such as hypertension and diabetes, obstructive sleep apnea, and heart disease. But there's also the neuroendocrine effects, such as the increase in adipocytes, release of aldosterone, and aldosterone is a powerful marker for fibrosis in the kidney. And so that really drives inflammation and fibrosis within the kidney. There is the ectopic lipid deposition, what I've shown you. It completely replaces the normal cells of the kidney. And there's also the external compression from carrying too much fat. So what is the implication of having CKD, having obesity for CKD patients? Well, I told you if you are obese and no CKD, you're at risk of developing CKD. If you have CKD, stage 1, you're at risk of progressing to 2, 3, and 4. So it increases your risk of progression. If you are unlucky and you get to the stage where you need transplantation, if you're obese, you can't be transplanted. I think we all know the risk of cardiovascular disease. There's an increased risk of hospitalization, increased risk of healthcare costs, reduction in quality of life, and a reduction of life expectancy. So it's all bad news. The treatment landscape is really changing rapidly. This is from the KDIGO 2024. This is the treatment for chronic kidney disease in general. But the KDIGO are currently working on a separate guidelines for obesity-related CKD. And we use this as a baseline with a bit of modification because it still is relevant. The first line of therapy is lifestyle, and this is very important, and I think it's been talked about quite a lot during the conference. The second line therapy is the SGLT2 inhibitors, the RASI therapy if patients have proteinuria, and then we come to the new kids on the block, which are the GLP-1s. This study was published in 2014. It's the Look Ahead, a randomized controlled trial looking at intensive lifestyle modification in patients with type 2 diabetes. There are about 5,000 patients, and the primary aim was looking at whether lifestyle intervention reduces cardiovascular disease, and it turned out to be a negative trial. But in this trial, they looked at a secondary analysis of the kidney outcomes, and what they found was if patients lost an average of about 4 kilos, they had a lower incidence of developing CKD. So lifestyle modification do work in terms of reducing the risk of developing CKD. This is the SGLT2 inhibitors, so dapagliflozin in patients who are obese with or without type 2 diabetes. And you can see here, you can see here that these are BMI of 25 to 35 to, 25 to 30, 30 to 35, and this is more than 30. And you can see that dapagliflozin reduces the progression of CKD and protects the kidney. And I think we know the mechanism behind that is the hyperfiltration, which I mentioned earlier. Now, we come to the new kids on the block, the GLP-1s. There has been a whole host of GLP-1 studies looking at the cardiovascular safety data, and they've all been proven to be successful. However, most of them had secondary analysis looking at the kidney, and this is the first trial that had a renal outcome-related trial. So it was asking the question, does semaglutide delay the progression of renal disease and cardiovascular disease in patients with type 2 diabetes and CKD? And this is the trial's design. So they included adults of above the age of 18 with CKD and type 2 diabetes. They had to have an HbA1c of less than 18 and an eGFR more than 25. Those with a higher eGFR had to have a higher level of proteinuria to get into the trial. The trial included more than 3,000 patients, was randomized to placebo and semaglutide, and it was supposed to take 5 years, but it terminated early because of overwhelming efficacy. The primary endpoint was looking at a reduction by 50% of eGFR, and onset of initiation of renal replacement therapy, renal death, or cardiovascular death. Very briefly, this is the baseline characteristics. You can see the majority of the patients have CKD stage 3, and they all have significant proteinuria. For us in nephrology, these are the patients with the highest risk because they're at risk of progressing towards kidney disease, they're at risk of dying from cardiovascular disease. And this is the trial results. You can see that patients who were given semaglutide had a reduction in the composite outcome, i.e. a reduction in the progression of renal disease by almost 24%. And there was a preservation in eGFR. Those who was treated with semaglutide had a better eGFR than those who were given placebo. If we look at the secondary endpoints, there was an 18% reduction in cardiovascular death and MACE in particular. In addition, there was also a reduction in all-cause mortality by 20%. For us, we needed to know the proteinuria data, and there was a significant reduction in proteinuria by almost 30 to 40%. Powerful stuff for us in nephrology. We've been a dead specialty for a long time, but this is really amazing results. Now, I've just told you that obesity has nothing to do with diabetes. What about the results in non-diabetics? Do we have to have diabetes to have CKD and obesity? Well, this is a trial that was published 3 weeks ago looking at exactly that. So these are patients who are overweight and obese with no diabetes. And they looked at semaglutide. This was published in Nature end of last month. And they looked at patients who are over the age of 18 with CKD and no diabetes. They had significant proteinuria. The exclusion criteria was diabetes and a recent cardiovascular event. They had about 100 patients or so. They were followed up for about 24 months, and this was an international trial, and the primary outcome was looking at the reduction in proteinuria. This is the baseline characteristics. You can see the majority of the patients' etiology was of glomerulonephritis, hypertensive kidney disease, and obesity-related CKD. The mean eGFR was about 64, and it was similar in both groups. This is the results. Pretty amazing results. A reduction by almost 52% in proteinuria. The FDA have advised that any drug that reduces proteinuria by 30% will infer cardiovascular and renal benefit. This has exceeded that, so it's gone down to 52%. And it's sustained throughout the trial. The difference between this and the flow is that they have used a higher dose of semaglutide, 2.4. In the flow, it was only 1 milligram, and they've up-titrated it according to the protocol. What about the other parameters? So there was a dip in eGFR in those patients who were given semaglutide. We don't fully understand this dip, but we think it's a protective effect, just as we see with the SGLT2 inhibitors, and I think it's a multifactorial, but nonetheless, towards the end of the trial, the eGFR plateaued and it reached exactly the same level as at the initiation eGFR. What about changes in weight and blood pressure? There's a significant reduction in weight by almost 10 kilos in these patients. There was an accompanying reduction in blood pressure by almost 8 to 10 millimeters of mercury. Pretty amazing. The normal or the usual blood pressure medication reduces your blood pressure by 3 to 5 millimeters of mercury, and you can see these numbers are pretty staggering. What about the HbA1c? These are non-diabetic patients. So there was a modest reduction in HbA1c, and there was one incident of hypoglycemia. But there was no details about how low the hypoglycemia was and for how long during this trial. In terms of the adverse events, non-surprising, it was mostly GI side effects, but it was well tolerated, and there was fewer side effects in the semaglutide group compared to the placebo. Just taking a peek into the future, so these are the trials that are coming out. So the top trials are cardiovascular outcome trials. The bottom trials are kidney disease trials. I've talked about the flow. I've talked about the SMART. There is the remodel. So the flow and the SMART are asking the question, does semaglutide reduce progression of CKD? And I think we know the answer to that. The remodel is asking why. Why does semaglutide reduce progression of CKD? And they're looking at about 100 patients or so who are undergoing repeated kidney biopsies, they're undergoing repeated MRI scans, and some cellular and molecular biomarkers to try and establish how semaglutide works. Looking at next year, so is the retatrutide. Retatrutide is a triple agonist, and there are reports that some patients lose up to 25 kilos with retatrutide. And I think this is the newer agent that we're all looking forward to, CagriSema. So this is an amylin receptor agonist, and there are reports of weight loss of 25% of body mass. I think if I was a surgeon, I'd be pretty perturbed about this because it would put me out of business. Now, talking at the surgeons, I think it would be unfair of me not to mention the good work they do. This is a trial comparing surgical treatment against medical treatment. It's slightly old now, from 2020, but essentially gastric bypass is a safe treatment, and in particular this trial looked at patients with type 2 diabetes, obese, who had CKD, so stage 2. And what they found was having gastric bypass induced remission more, reduced ACR further, and glycemic control and LDL much better than the medication. However, as I said, this was a slightly old trial. There was not that many patients on a GLP-1, GIP-1, and we now know the newer agents work much better. So we have to take this with a pinch of salt. So, in summary, the prevalence of, hopefully I can convince you that the prevalence of chronic kidney disease and obesity is increasing, and that obesity is an independent risk factor for developing CKD and is associated with significant morbidity and mortality. And newer agents such as SGLT2 inhibitors and GLP-1s are effective, but surgery still remains an effective treatment in early CKD. Thank you.
It's working now. It's working now. Thank you. If you have a patient with stage 3 kidney disease, and he's obese, and he's going now on high-protein diet. What's high-protein diet?
High-protein diet, yeah.
What's the impact on the EGFR?
So I think we've moved away from the protein restrictions. There are now newer trials to suggest that especially patients who are progressing faster, if they go to the point where they reach dialysis and they're malnutrition, they do significantly worse. So I tend not to restrict the protein the way that we used to do in the past. I'd say eat a moderate diet. I don't say eat a high-protein diet or restrict the protein, because that we now is harmful. So I tend to say a moderate diet is enough.
Yeah. We do have some obese patients who go, after advising them, they go to the gym and they indulge into, the powders and so on. So what is the impact on that in the EGFR and the albuminuria?
Yeah, so some of them take creatinine supplements, and that really gives us a wrong result. So the creatinine does tend to go up. But I tell the patients not to take the protein supplements because there are synthetic supplements inside that can actually cause kidney disease themselves. So I tell them to stop. Exercising in the gym, enough, we would encourage that, but taking supplements, I discourage all my patients from doing that.
Do we have any other questions? I have one question for you. Dr. Omer, as being in the CRM or CKM clinic, we've discussed a lot of cases together. So I have a question for you. Have you seen any, it's anecdotal, we haven't published it, with tirzepatide?
Yeah, thank you, Dr. Farhana, for being obviously the leader in setting up the CKM clinic in our hospital. But in terms of the tirzepatide data, there is the SURPASS studies that looking at secondary analysis, and there's significant reduction in proteinuria and preservation of EGFR. As I mentioned earlier, the FLOW is the first dedicated kidney trial, but from the tirzepatide secondary analysis, there is preservation of EGFR. And I think we're seeing that in our center because we have very large numbers of patients on it. And hopefully we'll be publishing that very soon.
Any further questions? We have one more if anyone has any questions. Thank you.
Thank you very much.
Let's go.